Good morning, everyone, and thanks for being here. The opioid crisis is one of the biggest public health problems in America. There are millions of people in this country addicted to opioids, both prescription painkillers like Vicodin and illicit opioids like heroin. Opioid overdoses kill about 50,000 people a year. That's more people than car accidents, it's more people than guns. In fact, it's the leading cause of accidental death in the United States. The crisis also costs about $500 billion a year, and beyond just dollars and cents, it leaves millions of people, millions of lives and families broken. Now, addressing the crisis has proven quite tricky. The opioid crisis, in many ways, it's a story of unintended consequences where well-intentioned policy actions have inadvertently made things worse. So in the first place, it was attempts to address untreated pain that led to widespread prescribing and, as a result, widespread addiction. And later on, attempts to reduce the misuse of opioids by changing the formulations of pills might have driven more people to use illicit opioids like heroin instead. So this is a really complex, tricky problem. And on top of that, the data that we have about this crisis, not to put too fine a point on it, they're crap. Drug use is highly stigmatized and it's often illegal, so self-reported data, which are most of what we have, are not going to be the most reliable. And we don't know a lot of the most basic parameters of this problem, things like what's the risk of overdose and what's the risk of developing opioid use disorder, more colloquially what you'd call addiction. Now, to put that in perspective, I also work on COVID, and with COVID, when you're talking about the most basic parameters of the disease, things like the reproductive rate or the infection fatality rate, we had starting estimates of these by January of last year, and we had good estimates by the summer. With the opioid crisis, we're talking about comparably fundamental parameters, and this crisis has been around for 25 or 30 years, and the state of our knowledge is still like COVID early last year, so that's really not great. And also, for obvious reasons, it's very hard to do any sort of policy testing or experiments on this problem. It's a unique set of circumstances, so it's very hard to learn from our mistakes. So recognizing these challenges, in 2017, National Academies of Science, Engineering, and Medicine published a report where they suggested that one thing we can do to better guide policymaking is build a model. A simulation model that synthesizes everything that we know about this problem and can help us to project the impacts that different policies might have. And that's where my work comes in. So for the last 2.5 years, I've been working with the Food and Drug Administration, the FDA, as well as a team at Harvard Medical School to develop exactly such a model. Now, this is a large project. There are a lot of people involved. I'm the lead modeler on this effort, and it's also the core of my dissertation work. Now, unlike the work that most of us here do, this project is not motivated by a theoretical research question. There isn't a major theoretical contribution here. Instead, the basic motivation and basic contribution of this work is practical. It's to build a model that lets us get better estimates of what's really driving this crisis, and hopefully, therefore, identify better policies to try to address it. So what are the main policies being considered? Well, the problem grew out of over-prescribing of opioids. As prescribing grew, so did the crisis. So most of the policies that are being considered try to address that. This is a graph from the CDC, and it reflects a pretty widespread assumption, an implicit assumption, that if it was caused by over-prescribing, it can be solved by reduced prescribing or reduced diversion of pills to the black market and so on. And we'll see in a bit whether those work. So with that said, let's take a look at the model. Our model tracks the US population through a number of different opioid use states. We have about 20 or so different state variables in the model. These variables represent people who misuse prescription or illicit opioids, people with opioid use disorder, where drug use becomes severe enough to be really problematic. We also track the people receiving certain forms of addiction treatment, or people in remission or recovery from use disorder. And the critical thing about this model is we drive the transitions between these states. So there's people in each of these states and they can transition between them. And we drive the rates of those transitions endogenously. That means those rates vary based on what's going on elsewhere in the model. So for instance, there's a social contagion effect where the more people there are using certain drugs in certain ways, the more likely it is that other people will pick up that behavior. There's also a risk perception feedback where as more people die from overdoses, the risk that people associate with drug use or use of those drugs is going to increase. And so new people are less likely to start using that drug. We also include several other details and effects. There's supply and demand effects on people's drug use and initiation. There are operational details on overdose deaths and overdose reversals. Reversals are important because not all overdoses are fatal, and with timely intervention, you can reverse an overdose and potentially save a life. And there's a few other details in there as well. Now, the reason it is critical to capture these details and all of these effects within the model is so that we can make realistic projections about how the system will respond and how people will respond to different policy interventions. And what we did was we took all of this structure along with the data that are available about historical patterns of opioid use, and we use that data and structure together to estimate the model and estimate its parameters. And we do that with maximum likelihood estimation, with Markov chain Monte Carlo MCMC to quantify the uncertainties. And the result of that estimation is that we get a pretty close reproduction of the historical trajectory of the opioid crisis. And you see that here. The blue lines are simulated model outputs. The gray dots are historical data. And these are a few of the historical data series that we use to calibrate the model. Things like initiation or incidence of opioid use, prevalence of use disorder, number of overdose deaths. Now, these phenomena, obviously in the real world, these phenomena are closely related to each other. And the model structure, it represents those relationships and it constrains how they're allowed to behave relative to one another. So the fact that across the board, we are able to get a reasonable reproduction of history under these constraints, with these structural constraints, that gives us some confidence that our model has captured the most important aspects of the underlying reality. In other words, that it's a good representation of the basic causal structure of the real system. And that in turn gives us confidence in the projections that we can make with the model. So let's look at some projections. The model tracks a wide range of different outcomes, and we're actually developing a tool for the FDA that makes it easy to do that. But for now, let's focus on two things. First, cumulative overdose deaths, that's how many people will die, and cumulative person years of use disorder. This is a good proxy for the overall quality of life impacts, health costs, social costs, and so on that arise from addiction. So as it turns out, most of the supply side policies that the FDA and many others have been considering, they don't make much of a difference. In the long term, they do help to reduce use disorder somewhat, but over the next 10 years or so, they hardly make a dent in deaths. And that's because there's a lot of inertia in this system. There are already millions of people with use disorder, and reducing prescribing at this point does not help them. And the vast majority of drug overdose deaths are coming from this group of people, and in particular from their exposure to fentanyl, which is a synthetic opioid that's far deadlier than heroin. In fact, this much, literally just a few grains, is a lethal dose. And fentanyl is increasingly prevalent. You might have heard about it yesterday on the news in the George Floyd trial. It's really common around here in New England, but it's obviously present and spreading across the whole country. So what can we do about that? Well, one thing we can do is increase the availability of naloxone or Narcan. Narcan, naloxone, is a life-saving medication that can reverse an opioid overdose, and making naloxone more widely available is a major policy priority right now. So what happens if we do that? Well, more naloxone does help to reduce overdose deaths, and that's great. But it's not a panacea. It's a stopgap because, again, if you look on the right, it does nothing to reduce use disorder. And one of the key insights that we've gotten from this model is it's really important to drain this pool of people as fast as we can because they're the ones at greatest risk of harm. But it's not easy to get people out of this state. right? Almost by definition, it is very hard to stop addiction. And it's only really with very careful combinations of interventions that we can start to do that. And the devil's really in the details, but basically, we need to make it easier for people with use disorder to access addiction treatment. We need to make it easier for medical professionals to provide that treatment. And at the same time, we need to improve how effective that treatment can be. Now, you might notice that none of the things I just mentioned, if you look at the graphs, these things don't seem to help very much at all. And on their own, they don't. However, in combination, they can make a huge difference. And that's really important to know, because if you change only some of these things, if you have piecemeal policies and not a very coordinated policy approach, you might see very little effect. And it's easy then to draw the wrong conclusion and think, this isn't really going to help. These things can and do help, and they can make a huge difference, but only in the right combinations with one another. And that's the sort of thing that we've been able to learn, the sort of insight that we can get from this model. There are no easy solutions to this crisis, and it will take patience and persistence to solve it. And if this model helps people to understand that, where I'm actually briefing a week from now, briefing FDA Center leadership on the model, and if it helps them to understand that and to make better policy decisions, then I hope it can help save lives in the years to come, and that would be worth the effort. Thank you.